Okay, so we're so honored to have Dr. Peter Leo sharing with us today about his experience in treating topical steroid withdrawal and his research findings in the treatment of TSW with Dupixent. And Dr. Leo has quite the bio. If you want, I can go ahead and read it all.
You don't have to.
But he's done such amazing work with the eczema community, and he's treated a number of our patients in the TSW community as well. He's the clinical assistant professor of dermatology and pediatrics at Northwestern University Feinberg School of Medicine, a fellow of the American Academy of Dermatology, and a diplomat of the American Board of Dermatology. He received his medical degree in formal training in acupuncture from Harvard Medical School. He's the founding director of the Chicago Integrative Eczema Center and has spoken nationally and internationally about eczema and atopic dermatitis, as well as alternative medicine. He remains active in clinical research, serves as a section editor for the Archives of Diseases in Childhood, and has published 2 textbooks and over 75 papers in the peer-reviewed literature. He's received a Leader of Distinction Award, a Presidential Citation from the American Academy of Dermatology, and numerous teaching awards. Dr. Leo is committed to providing the highest level of personalized care to patients of all ages. His special interests include pediatric dermatology, eczema, acne, dermatomyositis, that's a big one, and other inflammatory diseases of the skin, and he works to integrate alternative and complementary medicines in dermatology. And we are just so honored and thrilled to have you sharing with us today, Dr. Leo. One of your patients, Katie Loeffler, is here with her daughter, so she's excited to see you. And without further ado, if you want to take it, we're happy to hear.
Thank you very much. And yeah, please feel free to jump in with questions or comments. We're going to talk just for about 15 or 20 minutes, if that's okay, with some prepared stuff, and then we can chat about whatever you guys want to talk about. But I'm really interested in trying to help with this condition. I think it's one of those things we need. We need new ideas. We need new discoveries. And so I'm interested to tell you guys about what I found so far. My disclosure is that I do speak for Regeneron, the makers of Dupilumab, and I also do some studies with them. So we're just finishing up a quality of life study where we're taking pictures of patients, but it doesn't have anything to do with this directly. You know, I'm just, this is my own piece, and the paper we wrote had nothing to do with them. In fact, they were surprised we wrote it. Atopic dermatitis is such an interesting area, and it's incredibly hot right now. We are understanding that basically we don't understand it. That's the most powerful thing I think we're learning. The diagrams are getting more and more complex. The number of systems involved is getting more and more complex. So what was initially thought to be just an inflammation problem, or in the old days, maybe just a skin barrier problem or a hyperproliferation of the skin problem, now we know there is a whole cast of characters. There's an orchestra of chaos happening in our patients with atopic dermatitis, from the immune system going crazy to the skin barrier being damaged to the microbiome, all the healthy bacteria that are supposed to be there, and they're playing all these different roles. Well, they're all off kilter as well. And now we're learning about the nerve endings and how abnormal the nerve endings are and the blood vessels. So we have this entire crazy, chaotic maelstrom happening in the skin. And honestly, despite the fact, I don't know if the video blocks it, but you can see this is the number of publications on atopic dermatitis charted per year. And if you can see this, you know, in the 60s, 70s, and 80s, pretty low. And then in the 90s, it started exploding. And now it's doing this exponential growth. And so, I mean, this is my area of interest, but I can't keep up. I can't read all the papers. There's thousands of papers per year, many of which are, you know, really detailed and complex and huge studies. And so we're all trying to learn. And whenever somebody speaks with too much authority on it, I'm like, wow, it sounds like you have all the answers. You know, some doctor says, I got this figured out. I'm like, you must be really amazing, because there's a team of really, really dedicated people working together, and we can't put everything together yet. So I guess you've got all the answers. And what I say is it keeps me really, really humble. The more I learn, the more I realize I don't know. One of the interesting things too that's been going on is we're understanding more than ever before that this is not one condition. There are multiple sort of subtypes of this, and maybe in a few years when we're even smarter, we're going to be able to say, gosh, they're not subtypes, they're really different diseases, and we need to think about them differently. But this was from a recent study. It just came out in June, where they were able to identify different types of immune cell populations in different groups. And so they're really different diseases in a way. The immune system subtypes are totally separate and probably will require different kinds of treatment approaches and may respond differently to treatment, which gets me really interested, because you wonder, is somewhere in this chart, are there a group that the patients who are likely to develop TSW. And if we could identify them and say, you should not do steroids because these are particularly dangerous for you, we could potentially stop the whole process from happening. There might be other patients where in this group where you'd say, gosh, you know, nothing really works for you except for the steroids and the small quantities, so we have to be careful and so on. But hopefully, if we get some new developments and new ideas, we won't need to rely on steroids so much. This is another paper that came out very recently as well, looking at subtypes in terms of their history, just looking at what happens with natural history of the disease. And they identified these different subgroups, and it's really interesting. They have, does it move for you guys too if I move that? Did that? Cool, so you can see what these are. But they kind of identified these different groups. These are kids who develop it early, but then it persists. They kind of have it for a long, long time, you know, into their teens and probably into adulthood. Then there's kids who develop it a little bit later, like these kids here. So they kind of don't have much until here, and then it resolves late. And then there's a group that develops it early and disappears early, and so on. So it's like, what do these mean? How do we interpret this? Are these really different diseases? Are they different subtypes? I don't know, but it's really exciting because nobody has ever known this much about it. No one's ever talked about it this way. And so I'm hoping that we're going to learn more and more about, again, what do we do for these groups? Like, for example, for these kids, maybe we should just not treat them, wait it out. They're going to go away early. But for these kids, we got to treat them, right? Because it doesn't seem like it's going to go away. Or what if this is the group that responded badly to topical steroids? And if we didn't use steroids here, they wouldn't look like this. So we have all these unanswered questions that we need to figure out. Let's see here. Here we go. And they also were able to show different groups have different features. So for example, with this group, the late onset resolving, they have a really strong family history. This early onset persistent was much more common in boys than girls. This group here, the mid onset resolving, has the strongest correlation with asthma. So it's like, wow, these are really, really unique and different. And so that brings us to TSW, which is something that I am still learning about. And I heard about it probably the first time, maybe 5 or 6 years ago. I hadn't really heard much about it before then. And we put together this paper, this was from 2015, where we took our first stab at it, just kind of what's been written, just kind of let's review the papers that are out there. Let's try to start with some baseline to understanding this. And this was, you know, a very imperfect paper, but it sort of got the word out. It sort of helped start the definition, which I'm grateful for because you kind of have to start somewhere. And the way we think about it, you know, is that it is still, unfortunately, poorly understood. It is an adverse effect of topical steroids or systemic steroids. So it can be both. And many of my most severe patients really have been exposed to oral steroids or even injectable steroids as well. But I don't think you have to be. I think it can even be just some topicals. We know that it's been most commonly described in adult women, and usually face and genital areas are kind of the description, but that's just what's been described. That doesn't mean that that's what's actually happening. Sometimes the cases that are written up are not reflective of what's going on in the real world. And I think to boil it down, like the message I try to give other doctors and healthcare practitioners is the things we're really looking for, the warning signs, if you will, are when we see the confluent erythema, the redness kind of in big areas appearing after you stop therapy. So I view that as sort of a worrisome abnormal sign. If you stop the steroids and things get really, really red within days or weeks, that to me is an automatic red flag. Stinging and burning seem to be more prominent than in regular atopic dermatitis. And then the biggest thing for me, what I'm always looking for and listening for, is this third one here, that we have this escalating need for steroids. It keeps going up and up and up instead of seeing a remission kind of effect where people will get better and need less over time. So one of the people I want to send a shout out to is Dr. Shiri. She is based in Australia, and she is not a dermatologist, so she has a particularly tough battle to get her papers published, but she has been really, really dedicated to learning about the disease and writing about the disease. And I've told her I want to help her in any way I can and see if we can keep getting the word out. But she did a really nice paper in the journal Dermatitis and really started to lay out some of the words and phrases that you guys know very well, but other healthcare folks were not, conventional medicine folks will not really know the concept of the red sleeve sign, the headlight sign, the elephant wrinkles. And so this is, again, important foundational work. And I know it's really frustrating because when you try to bring a new concept in, it's slow and floppy and difficult, but this is how it looks. It starts out with these little points of light, and then hopefully people will start seeing it more and more. So what is going on here? What is the cause of this? And I can just tell you, we don't know. And again, you guys know that there are people who don't even think it's a real thing. There's still argument whether it exists. I'm far past that point, but I'm really trying to figure out what's going on. One of the theories that's really compelling to me is that the topical corticosteroids have an effect on the blood vessels in particular. So we know it's affecting both the immune system, of course, but it also has a powerful effect on blood vessels. And in fact, you know, the way that they rank the potency of steroids is they actually put a little bit on the arm and they see how blanched it gets, how vasoconstricted it gets. And so that's called the Stoughton test, and that is the proxy to know how strong a steroid is. It's something that's been used for a long time. And so we know there's this vasoconstriction effect. And one thought is that this causes a really strange dysregulation in some people that then they start making huge vasodilation. The blood vessels open up, tons of blood flow. This brings more inflammatory cells. And there's something to do with the nitric oxide, which is one of the flare triggers for a lot of people. It seems like nitric oxide release makes everything go crazy. And so some patients may just be very sensitive on this domain where if you even use a little bit of steroids, you can trigger this abnormal response where now it's gone haywire. We know that this rebound effect can happen even in sort of normal people that maybe won't go on to true TSW, but then there's a group where it seems super sensitive, but there probably is a spectrum, right? There's probably a group of people that maybe don't do well, but only a few weeks later and they're back to normal. Other people, maybe a few months. And then you have folks that are going on years. And those are the folks I'm most worried about, you know, where people come in to see me and they say, I think I have TSW. And I say, okay, when was the last time you've used any kind of steroid, topical, systemic? And sometimes it's startling. People will say, you know, 4 years ago. And that I feel is a real thing, but it's very different than the people who just needed a month or two, right? This is a totally separate group. And they tend to be the most miserable patients. They're still really red. They're weepy. They're often infected too. Staph bacteria is having a blast because it's open, weepy skin everywhere. And they're not sleeping well. They're getting run down, you know, and you're in this deep, deep vicious cycle of it too. So I really feel like those patients need help. And my job is to try to help people. So what can we do? Well, there's been a few different things reported. Tetracycline antibiotics have been used. They kill bacteria, but they also have an anti-inflammatory effect. And we use that a lot in both acne and rosacea. So that can be helpful in some patients. Antihistamines can sometimes help with some of the vasodilation and blood vessel stuff and some of the itch. Calcineurin inhibitors, so this would be cyclosporin by mouth or tacrolimus by topical route. Those can help some patients, although I know that there are other patients who feel like that can actually contribute as well. So we have to be careful with those. They're pretty powerful immunosuppressants. Ultraviolet therapy can help some patients. And then even people have actually talked about using steroids again. I don't do that. I don't like to do that, but I get their thought that maybe if you kind of hit the reset button and go slowly, you can get people out of it. And it may work for certain patients, but I'm gun shy. I really prefer to avoid steroids altogether when I have even the concern of this. Now, phototherapy is one of my favorite treatments. You come into a dermatology office and you basically get in this little light box. It's like an upright tanning booth. Most patients come 2 to 3 times per week, and it does a lot of stuff. It has a direct effect on the blood vessels. It helps with the vasoconstriction. It's directly anti-itch. It probably boosts our vitamin D and some of the things that help fight bacteria on the skin. We have these cathelicidins that fight bad bacteria. And so it's doing a lot, and it's anti-inflammatory. The problem is it's really slow. It probably takes 6 or 8 weeks to kick in for most people. And a lot of the patients we're seeing are quite miserable. So that's a long time to wait. Number 2, it is expensive. Most of the time insurance will cover it, but there's often still a copay. And even if there's not, there's expensive time. You have to come into an office 2 to 3 times a week. It's not always possible. And of course, it doesn't work in everybody. In my experience, it probably works in about half to 3/4 of patients in terms of getting them better. So it's something I like to think about and offer, but sometimes it's a no-go. And so that really brought us to Dupilumab. And Dupilumab is kind of interesting new medicine. It came out just about 1.5 years ago. It is an antibody. So it's truly just a little tiny human antibody, just like we have millions of antibodies running through our blood, which help us protect against infections and do all sorts of things in our body. And this particular antibody is designed to bind to this receptor on the cells that the cytokine, the cell messenger called IL-4 and IL-13, they bind to that. We know when they bind to that receptor, they trigger an inflammation cascade. In particular, they trigger this allergic type inflammation that seems to play a role in eczema. It plays a role in asthma. It probably plays a role in rhinitis, people that get the hay fever kind of stuff, and maybe other things, maybe food allergies and stuff. And we think in the patients who have these conditions, it's going crazy for reasons we don't know, but it's too much. And so this little antibody can block this cascade and cool it down without screwing up the rest of the immune system. That's kind of the magic part about it. Up until last year, we didn't have any way to do that. To do the same thing, you'd have to shut down the entire system and put people in a state of immunosuppression, which we try not to do, put you at risk for all these things. What's so nice about this is it's more of an anti-inflammatory that's targeted. So it really makes our life a little bit easier. Right now, it's approved for moderate to severe atopic dermatitis in adults only, and it's injected every 2 weeks. People do it themselves, which is easy to do. You don't have to come into the office to get it or go into a hospital or anything like that. When we look at the studies that were submitted to the FDA before it got approved, it actually did very, very well. And you can actually see how it did both with the EASY score, which is the Eczema Area Severity Index, kind of a measurement of eczema. We can see how well it did and how quickly it worked in clearing up the eczema. And this compared to the placebo group. And there's an effect for placebo. There's no doubt, that's why we have to run stuff against the placebo, because if you just looked at this, say, hey, people did get better. And there's, probably a number of reasons for this. One of which is the power of belief matters. Our body can do pretty amazing things. And so when people are excited and motivated about a treatment, you do see an effect. And especially with diseases that are stress induced like eczema, I think the mind has some power, but clearly not enough. It's not getting people to where they need to be, but the drug really helps. And then we look at itch, and it really works fast. Like in the first week, you can see it working and then continues to do great and sustain. And so it's done very, very well in atopic dermatitis, but it does have some side effects and issues that are worth thinking about. Even though it seems safer than the other things, it can cause this conjunctivitis, this eye itch and redness and inflammation, and probably around 10% of patients. Now, that means 90% of patients are okay. They don't have to worry about it. But for those 10%, it can be unpleasant, and it can be bad enough that we actually have to stop the medicine. We're saying, we've tried. We're doing everything we can to get your eye comfortable, but I'm not happy with what you're needing to do for this, and I don't want to cause trouble. So we've had to stop it in a handful of patients. When you're on it, you're not supposed to receive live vaccines. You can get the flu shot. You can get like the shingles shot, but if you were going to travel, for example, you got to be really careful, because that can, we don't know if your body would react differently. And then sometimes people can have a reaction to where they inject the medicine. So those are the big things. The other thing is the cost. It's really expensive. It's on the order of about $37,000 per year, usually covered by insurance. Fortunately, it'd be hard for anybody to do that unless you're Bill Gates. So what's really interesting about this medicine is that in some ways it's the opposite of steroids, right? We think one of the things we know about steroids is that they really help, right? They control the symptoms really fast. Magic. But when you stop, things often rebound. They go up. They get worse than where they were. And so one of the things we're really interested in is, can we induce this remission state? And this is what I try for all my patients. I definitely do not always succeed, but we do have some successes, and those are really worth celebrating, where it's spiky in the beginning. It's like, I had a bad flare up, I used the treatment and it was quiet for a little, but then bam, another pretty bad flare up. But if we do our job, we think we can kind of get it under control, where people then say, I'm good. Like, I'm just not flaring anymore. I don't need medicine. I haven't touched anything. And, we have patients come in and I say, wait, I haven't seen you since last year. How have you been? And they're like, great. I haven't refilled anything because I haven't needed anything. I'm medicine free. And we do our little happy dance and we celebrate and we say, you're good. You're in remission. You call me if you need me. I'm not going to even refill your stuff. You don't need any medicine now. Go, enjoy. And that's what we want for everybody. I can't do that for everybody, but we try. And so what's really interesting about Dupilumab is that it seems to put people in this. And so we wrote up this little paper, just came out a couple months ago, where we looked at patients who had done well on it. And then when they stopped it, they actually stayed pretty clear. So again, kind of the opposite of what we expect with steroids. You're terrible, you know, when you start it, then you get much better when you're on it, and then when you stop, worse than ever before. We didn't see that at all, thank goodness. And I didn't know what to expect, honestly. I mean, that's why we wrote this up, because I said, I'm not sure what will happen. But you can see here, for example, this patient number 1, she started out with an IGA score, the severity score of 3. So that's a moderate case. And then when she was on the treatment, she dropped down to a 1, which is almost clear. So maybe she had a couple of little tiny red spots. She was doing great. She was doing so well. She said, I want to take a break. I just want to come off. I said, no problem. And she came off, and I saw her a number of weeks later, almost 2 months later, and she was only up to mild, maybe a little bit more some areas, but months off of drug. And again, we can see that pattern over and over again. So most patients really stayed pretty clear, and not a single patient got back up to where they were before. So not only did they not rebound, they didn't even get back to their baseline, which is kind of exciting. And so that kind of brings us to, what about in TSW? So we had a group of patients, a small group, admittedly, you know, this is still fairly small numbers, but where we really wanted to offer something, and we said, let's try it. So we put this paper out pretty recently, and here's what we saw. Patients were all pretty darn bad. So this is the worst. It's a scale of 0 to 4. So more than half of these poor folks were 4 on the eczema scale. Now, you know, whether or not, is it eczema alone? Is it just TSW? What's the difference? Can you tell? I don't know. I sometimes can't really tell the difference, but they were severe patients. They looked really, really bad, and they were suffering. And when we started them on the medicine, everybody got better. Not clear, but definitely better. So this super severe one dropped down to moderate. This super severe one dropped down to mild. This super severe one, mild. This moderate one dropped down to almost clear and almost clear. And look at the body surface area, 60% at the start. Once they were on it, down to 25% body involvement, 70% down to 15, 70% down to 20. So it really had an impact. It's not the cure. It's not the secret. It's probably not the answer for everybody. We happen to just have a decent cohort of folks that did well. I have no doubt some people will try it and it will not agree with them or will not help. But boy, if we could help even these 5 people, even temporarily, I feel really happy about that, because the people that I'm interested in really trying to give some relief to are the people that have been fighting this for a long time. And I'm worried that it may not be a temporary withdrawal anymore. I feel like once patients have passed the 1-year mark, or honestly, probably even the 6-month mark, I worry that the chance of them getting to the point where they're just happy-go-lucky and clear, I think that chance starts to go down. I don't know that, but that's my fear. And so when patients come in having suffered for a long time, I say, gosh, I want it to be gone too. I don't want you to have to deal with this, but can I help? Can we do something? Can we work together to find something to help you get through this and hopefully put you in sort of a remission or make that process go faster? So in conclusion, TSW is terrible. It affects people in one of the most horrible ways I've seen of all the conditions that I treat. We really need to understand this better. We need to validate this. We need to get everybody on board so we can get all the right people thinking about this to get people better. But importantly, some of the cases really don't seem to just get better over time. And so I guess my question mark is just to get it out there. Do they all eventually go away? Or are there some people who maybe are the way I like to think of it is the immune system is permanently damaged, or at least long-term damage from the steroids. And so it's not a withdrawal anymore. It's a steroid-induced flare. It's a steroid-induced kind of state that now we're stuck in. And so maybe we need to do something. And I keep calling for better treatments and better diagnostic, recognition of the disease, so we can minimize the suffering while people continue to stay away from those steroids. Thank you so much for your attention.
Thank you, Dr. Leo. That was awesome. So we're going to open it up for questions just for a few minutes, because I know that you have a busy day of traveling. So if you have some questions on mind, does anybody have one? You want to come up, Shuhan? Shuhan is a student at Georgia Tech here. Oh, she's your current patient as well. Come up so he can see you.
Yeah, I have a quick question. So at the beginning of your presentation, you said that steroids inhibit nitric oxide. So why isn't
Yes.
or like medicines that actually do the opposite? Because I was wondering maybe if that would probably actually help with symptoms.
Yeah, it's such a great thought. So one of the things that seems to block it actually is vitamin B12. And so particularly when it's topical. So that was one of the few things that we found that seems to work. And we kind of have it, we write it out as pink magic, and it's the vitamin B12 cream. So that's one of the things that does it. The problem is some of the other things that do it make you vasodilate because it's playing kind of two roles. So we don't, to my knowledge, I don't know of any other medicines offhand that would block it the way we want it to be blocked, except for the vitamin B12.
Yeah, thank you.
Of course. Thank you. Great question.
We got another question coming here.
Hi, Dr. Leo. I'm Jody Orr. Thank you so much for this presentation. It's phenomenal to actually hear a doctor that says this is a real thing and we're not crazy. So thank you, first of all, for that. I just would like to get your perspective on why the rash spreads so much. I'm almost 3 years and mine is just, I've got red sleeves that didn't really hit me until maybe, I don't know, 18 months. I don't understand it. It drives me nuts.
So maybe give it history.
I hear you.
Well, I used it on my face. I used Desinite on the face. I had 1 round of prednisone. I was using clobetasol, just a little bit on the inside of my arms, very, very sparingly, all of it. Thank God. And that's been 2.5, almost 3 years.
So, yeah, I mean, it might be that kind of a situation where it's not a withdrawal in the classical sense anymore, but that whatever it was, the steroid triggered a change. And so now you get kind of this kindling effect. The immune system just kind of revs itself up and it spreads like a wildfire. And then once that happens, we really get stuck in this vicious cycle, kind of like eczema itself. It's the same concept, maybe just a different version of it that's now been altered by the steroid. It sort of shifted it into a different gear. But honestly, I wish I knew. I don't really know, but that's my speculation. So if I had a patient like you, I'd say, gosh, I'm worried. It's been so long and you're getting new areas despite being careful to avoid the steroids. I'm worried that just waiting might not be enough and you could be waiting a very long time. Maybe it won't go away on its own. Maybe it's just shifted into a bad phase. So I would say, what can we do to sort of try to shut this off and get that remission kind of concept going, if anything? And again, the problem is our magic tricks box is small. We only have a couple things. So sometimes we try a few things and if they don't work, it's kind of like, all right, well, let's just stay in touch and hopefully we'll find something as new developments come about. But it could be worth thinking about the Dupilumab. It could be worth trying the light therapy if you haven't already. There may be things. You could even try the Pink Magic cream. You could, and I'll send the recipe again. You can have a local pharmacy make it for you. It's really just a vitamin B12 in a cream to see if those kinds of things might help cool it down and help break the cycle.
Yeah, I'm just trying to understand the science or the mechanism behind it. I'm such a logical person that it really bothers me that I don't understand why it's taken 8 months for something even worse to happen once I quit a medicine. Just logically does not make any sense. I know.
I'm with you.
That's something to figure out. Okay. Thank you so much. Appreciate it.
Of course.
Anybody else have questions? Okay, I'll ask you one real quick. So we have had one of our members do quite a lot of research. She's in science, and she believes that there's a lot of mast cell involvement, which you talked about the nitric oxide, and that mast cells are depleted when you use steroids. What are your thoughts on that as far as, because the mast cells are what causes the flushing, right? The red that comes and flushes, and the overreaction to some of these triggers, like, whether it's like an allergen environmentally or it could be a food, but a lot of us experience that sort of thing where there's just like a bright flushing, a burning happening. And like Jody said, sometimes it takes a while for that to start being activated. It doesn't happen just right away. Do you have any thoughts on that?
Yeah, I mean, it's almost for sure there's the mast cells are playing some role. I totally agree. I mean, it makes a lot of sense. The mast cells, produce all the histamine, which can do exactly that. I will say there are other conditions where the mast cells are overactive. So, for example, there's a condition called TMEP, It's part of this group of conditions called urticaria pigmentosa, where people have tons of mast cells and they go crazy, and they can have massive mast cell release. For example, if they go swimming in like a cold pool, that will stimulate, or if they get into too hot of a bathtub, any kind of extreme will trigger it. And they present ultimately with anaphylaxis, because when you release enough histamine, you start you turn beet red, but then you swell up, hive up, and they can actually die. They can actually have anaphylactic shock from it. So they're the most extreme. And unfortunately for them, they don't really stay depleted. They keep, the mast cells keep refilling and keep causing this over and over. So they can be in some trouble. We have to give them like special instructions about when they have surgery. They can't go under general anesthesia very easily, because that's another thing that can trigger them, and they can go into the anaphylactic shock. So there's probably something involving the mast cells here. It's just not clear to me, exactly what it is or how to address it, because we certainly tried mast cell stabilizers in a couple of the patients with TSW, and it didn't seem to do too much either. But again, maybe it's not so simple, right? That's the tricky part about this. Maybe that's not enough. You need to do something different altogether.
Yeah, because it seems like a lot of our people don't respond to antihistamines much at all. They use them more for sleeping than to calm the itch down. There's one really interesting thing that we've been finding too, as we've been testing our raw data a lot through 23andMe and Ancestry. You can upload that into Prometheus and these different platforms. And a lot of us are coming up with a certain gene mutation called a CYP3A5 non-expressor, which in the description, it talks about this is the mutation that metabolizes steroids, and there are different variants of it. But we're wondering if maybe that could be part of the issue, that we're having toxicity that's, leading to these different conditions, like, with the mast cells and some of the other things going on. Is there something that you could recommend us doing to kind of go in that direction and figure out, is this really our issue? Could this be one of the biomarkers we could look for?
That's super exciting to me. Yes. I mean, I think the next step for that, I actually thank you for telling me that. I did not know that. The next step would be, we've got to find like a geneticist or a genetics lab. And there are people who study this exact kind of thing. They look at different drug metabolism. Folks, we need to see if we can find someone. I know in Boston, at Boston Children's, there was one who did it. And maybe see if they would be willing to do a little study, get a group of folks and do, the proper testing to actually show the levels. That could be a big deal. So I completely love this line of thought. Boy, that would be a satisfying answer. It's like, hey, this group of people do not metabolize steroids normally, and so they act on the system in ways that you don't understand. So you can't do this for them. Oh, that's fabulous. Yeah.
Yeah, we found with that same gene mutation, tacromylus and cyclosporin are also included in that, which I thought was kind of interesting, because some of our members don't respond to cyclosporin as well. I know a lot of us have been on Protopic, including myself, and it seems like those who use steroids and Protopic, it seems to be prolonged. So in my case, we were talking about the length of it, and if it goes past a certain length, I know even Dr. Rappaport believes that, then it's not topical steroid withdrawal anymore. Mine was very severe for about 2 years, but it just has been, a very slow healing progression, where it was the burning that has changed for me. And it took up to 5 years for the burning to completely dissipate. And, the last part to go was around my lymph nodes under my arms. But that took such a long time. It was full body burning. I mean, from top to bottom, I was bedridden 1.5 years, couldn't even move, like, to my side. So that's one of the key factors of defining this disease, I think, is the burning is so different than regular eczema, and that it took that long to dissipate. And that's why I was wondering, okay, if we're not metabolizing steroids, is it possible that they're being stored in cell wall, in muscles and bones, and wherever the body's putting it, and then slowly over time it's releasing it back into the system to get rid of it maybe through the skin, if it can't break down in the kidneys or the liver. But that's just a thought. But I like your suggestion of reaching out to Boston's and some of these other places to see if we could start a small study, because it doesn't seem like that would be that difficult. We just submit a sample, right?
No, absolutely.
Okay, cool. Well, thank you so very much for your time. It was great to hear from you.
Thank you for having me.
Yeah, hope you have wonderful travels and whatever is ahead next for you.
Thank you, guys. Have a great day. We'll see you soon.
All right, bye-bye.